Thanks for everybody for being here. As stated, we're going to talk about reimagining the treatment of deep venous disease. What we're going to kind of go over is some background on what deep venous disease is and the prevalence that it occurs. And then we'll kind of move into a little bit of the data that was published, present a case, and then finally come up with a conclusion. So our first goal when we look at these patients is we want to have the patient in mind. The big bucket is we want to care for patients' overall long-term health when we looked at this problem that's going on. And with that, we wanted to understand what is chronic venous insufficiency and how often does it occur. So with that, we had chronic venous insufficiency occurring in 10 to 35% of US adults. So it's a problem that's widespread, and it's not really known much about outside of the medical community. We do have venous ulcers are the most common form of leg ulcers in the world. So that's kind of something that's staggering. It's not on the arterial side, but actually the venous side. And we have 4.6 million lost workdays annually due to this disease process. So it's something that is a severe financial impact for our market. The second bucket is we want to ensure patients are aware of all their treatment options. So when we looked at the treatment options, we found that there's kind of 4 key buckets. The first bucket is lifestyle changes. That being diet, exercise, putting your feet up at the end of the day if your legs are swollen, those types of changes that are going on. The next being medication that you can take, particularly if you have AFib or something of that nature that can cause swelling in your legs. We also have compression therapy. You think of that compression stockings that you're wearing on a daily basis. And then vascular and endovascular surgical options. That's similar to vein stripping or using ablation techniques in that regard. And then the last thing we wanted to understand is provide the most appropriate treatment option for each patient. And that was important for us, as we want to find out what the underlying disease is so that we're treating that and we're not just treating symptoms. So to continue with the scope of the problem, what we wanted to also understand too is some values around that. The annual treatment cost of venous ulcers in the US is $3 billion annually. So again, a high healthcare burden. 22% of US adults suffer from chronic venous insufficiency. And with venous insufficiency, we're usually talking about the iliac and femoral veins. It's the #1 worldwide cause of lower extremity ulcers. We have 4.6 million workdays lost annually, and 600,000 new venous ulcers are diagnosed each year in the US alone. So again, a very widespread disease that we're trying to figure out why do patients get this, and then how do we treat them. So with that, you could say, why is Philips into this and trying to understand it? The reason being is IVUS. And IVUS has been proven to help understand the underlying disease that's causing this to occur, and then we can tailor a therapy option for the patient after that. Due to some seminal papers that have been done, it's caused the SVS and AVF guidelines to recommend IVUS as a 1B indication. In there, they said IVUS is important in assessing the morphology of the vessel wall, identifying lesions such as trabeculations, frozen valves, mural thickness, and external compression that are not seen with conventional contrast venography, and that's what the important piece is. To give you some further data to go along with this is there was a lot of papers published by Negus, Ragu, and Neglin to understand this disease process and how IVUS plays a role into it. What we found was that the venography has a poor diagnostic sensitivity in identifying the disease. They also found that 34% of patients with chronic venous disease symptoms had iliac vein obstruction, lesions that appeared normal on venography. So that means 34% of the time, venography was normal, yet they had an actual obstruction occurring. They also observed that collaterals were only present in 43% of the limbs that were stented. And that's important because typically with a venography, what you're looking for in this disease process is some irregularities that are happening proximally, as you can see with the arrows, and then you're looking for collateral flow to come through as well. And that's usually a telltale sign that something's going on proximally. So if you're not seeing those collaterals 57% of the time, again, you could get into a situation where the patient's leaving the table with an undiagnosed issue. So what we did was the video trial. The video trial was designed, it was 10 centers involved globally. It was a single-arm study, and the workflow for the trial is somebody had to come in with a seat 4 through 6 that have failed conventional treatment that we went over earlier. They then came to the cath lab and had multiplanar venography. After that multiplanar venography was performed, the physician was asked, how would you treat this patient? And so they had to write down their treatment strategy. Would you stent? Would you not? How long would the stent be? Where would you place it? Would you do both sides or a single side? So after that was documented, they then would put in an IVUS catheter and then be asked that same set of questions. And with it, what we found is the treatment strategy changed in 57 of the 100 patients. So it went to the fact that, again, the venography wasn't exactly telling us the whole story, that IVUS was giving us greater information about this patient population and how to treat them, to the point that 35 of these patients, the treatment plan changed from no treatment to stent placement. 13 changed with the number of stents being planned to place, whether it be 1 or 2 or none to something. And then 6 changed from plan from no treatment to other sorts of intervention that may be in a venous ablation or some other surgical options. And then 3 changed plan from treatment to no treatment. So it was a very kind of observational study that allowed us to determine that the venography is not really telling us as much as we should about these patients, and then what should we do with them afterwards. So in conclusion of the study, the authors essentially wrote, conventional multiplanar venography combined with IVUS is more sensitive than CMPV alone in identifying and quantifying iliofemoral vein obstructive lesions. So now I'm going to kind of do a little case presentation on somebody that we'd normally see. So a common scenario, usually we'll have anywhere from a 30 to 65 or 70-year-old male or female that'll come in. They'll have failed compression therapy, they'll have a venous wound, something will be going on, and the patient isn't getting any better despite us treating them optimally at this point in time. So they come into the cath lab, we do multiplanar venography. Once we do that, we then have several questions that we start asking ourselves. One is, should we stent or not? The next, stenting across the inguinal ligament, should we do it? Should we stent into the IVC? Do we pre-dilate or not pre-dilate? Balloon sizing and pressure for non-thrombotic versus thrombotic. That's the other thing about this disease process. It's not just these non-thrombotic May-Thurner traditional cases that you would think of. It's also thrombotic cases and also patients that have Rodinsky disease as well. And then measuring the difference, the reference difficult or not possible to do with long diffuse disease. That really pertains to Rodinsky and also thrombotic patients. So once we do that, we take a venogram. We see that there's a discrepancy that's occurring proximal. We have thinning of dye where the artery crosses the vein, so this is kind of what we would typically see in this disease process. So then we do multiplanar venography. We take a little bit better picture. This view, AP and lateral view, again, we see the thinning of dye and we see a collateral coming in. But again, the presence of collaterals was not seen in 57% of patients that were stented by Raju-Neglin. So again, just because you don't have collaterals doesn't mean you don't have something going on. So in this particular patient, we did IVUS. There's pre-stent and post-stent. Pre-stent, what you'll see is a nice big iliac vein. As we pull the IVUS down, you're going to see that vein start to compress and become very small. Right there. And that's what's causing the issue. It's causing a back pressure to occur, which causes the leg to swell. You cause venous ulceration. The fix to that at this point in time is venous stenting. So in the post-stent, we put a nice wall stent in. With the wall stent, we were able to achieve basically our landing zones and how big the wall stent should be. So that's the treatment option. The question now becomes, after this, is we've kind of proved, okay, venography alone is not enough to diagnose the disease. We need to use IVUS to help with that. When we do this treatment, does the patient get better? And we're designing a trial right now in combination with stent companies to look at that type of treatment algorithm and see if that's going to benefit the patient long term. If it does, great. If not, we're going to still learn a lot more information about this disease process that we don't really know that much about.